guide all of us. So it is very important that the whosoever hacked our system before would like to hack it again. But it is our request that we are doing it for the community, for the people, to educate them, to teach them, to guide them, and to help them that how they can treat themselves or how they can make sure that they are fine, especially the patients who are diabetic and with COVID-19. So hopefully this session will go smoothly now. Unfortunately, we will not allow anyone to enter into a Zoom meeting now. So it will be live on Facebook. So by all means, post your questions on the Facebook page. Dr. Rahat Ali, it's back to you.
Thank you very much. Are you able to hear me at all? Very good, very good. Apologies for the interruption again, and apologies that we will not be allowing anybody to join our Zoom session. So back to perhaps the start. So you would be considering atypical presentations in anybody who is admitted with COVID and has already known to have diabetes or can develop new onset of diabetes. So you should be considering DK, euglycemic DK in both type 1 and type 2 diabetes patients, mixed DK and HHS phenomena, which is hyperosmolar hyperketotic state, so hyperosmolar hyperglycemic state, and DK or HHS in a newly diagnosed diabetes. So you already know the criteria for DK and HHS. The messages are you must be checking glucose in all patients who are admitted with COVID, whether they have diabetes or not. And you must be checking their venous glucose, especially in patients who have higher blood sugar of more than 33 millimole per liter, which is about I think 600. Any patient who's admitted to the hospital should have their acid-base balance checked, and all patients who have diabetes, metabolic acidosis, or who have who are very unwell should have their ketones checked. You should be following your usual protocol of DK and HHS treatment, which is IV fluids and IV insulin. You should be considered stopping the oral medications, and I've talked about why we would not ideally want patients to be on metformin, SGLT2 inhibitors, and GLP-1 agonists. We talked about early administration of insulin and early involvement of diabetes team, and individualizing whether you would want patients to start on subcutaneous insulin or IV insulin. Then we talked about individualizing fluid prescription. You would want to perhaps give fluids cautiously in older patients and patients who have higher comorbidities, especially who are at risk of cardiovascular disease and a risk of heart failure. And the ongoing fluid assessment must continue. Electrolyte problems because of insulin, hypokalemia, refeeding issues, for example, problems with magnesium, calcium, phosphate, must be checked and replaced as appropriate. Must be checking QT intervals, and if you have to replace these electrolytes on the wards, you must be taking ITU advice if appropriate. Now, going to hypoglycemia, patients who have reduced oral intake. Now, our case 4 was a lady who was 89-year-old who was admitted with confusion and delirium. She probably had exacerbation of delirium, not just because of the infection, but also because of the fact that she had hypoglycemia. And the hypoglycemia is usually caused by reduced oral intake, sepsis, although sepsis sometimes causes hyperglycemia, but it can also cause hypoglycemia. Food interruptions due to proning, adjustment of diabetes medications, and also the fact that some patients are on diabetes medications. For example, that lady was on 34 units of insulin. She's at really high risk. If she doesn't eat anything, she will definitely get hypoglycemia. So treat hypoglycemia appropriately, give them oral glucose or IM glucagon as needed. I'm not going to go into the detail of that. Patients with diabetes and COVID are at very high risk of venous thromboembolism, so they must all receive at least prophylactic heparin. The risk is higher in HHS, as you all know. And you must all consider diagnosing and treating coexisting problems, for example, silent myocardial infarction, pulmonary embolism, DVTs, cardiovascular disease, cerebrovascular accidents, even thyroid disease, including thyrotoxicosis, and some patients have actually presented with silent pancreatitis. So appropriate tests should be carried out. All patients should have their feet assessment done, and high-risk patients should also have their feet protection in the form of heel pads, low-pressure mattresses, etc. If there are supply issues, for example, if the patient is on an insulin pump and you are unable to get it in your hospital setting, try and give them subcutaneous insulin. If you are really stuck, then the last option is VRII, which is IV insulin. But discuss with your diabetes specialist, nurse, or endocrinology consultant. All patients who have DK and HHS should be seen by senior endocrinologist in the hospital, and other patients who have steroid-induced hyperglycemia should all have input from your local diabetes team. I think it's important to mention that a lot of people, unfortunately, will die of COVID, and it is important that they do not suffer at the end of their life due to very high glucose levels that could cause potentially dehydration, and low glucose levels. So aim for a glucose of 6 to 15, 8 to 20, whatever you think the individualization works, but don't aim for a very tight glucose levels, tight glucose level. So I'm going to be sharing some slides here. These are about how you would institute glucose monitoring. So these are the patients who are not known to have diabetes. You must be checking their glucose levels 4 times a day for 48 hours and checking their HbA1c. If the glucose levels are within the target range, which is about 6 to 12 millimole per liter, which in the Pakistani second, milligram per deciliter is 108, sorry, I tend to get confused with this, 108 to 216. If the blood sugars are satisfactory, that is, blood sugars are all less than 12, then you should just be checking their glucose levels after their before their evening meal, at about 5 o'clock, because this is the time where patients have the highest level of glycemia. But if the patient has hyperglycemia, which is blood sugars more than 12, then you follow the insulin protocol, which I'll share shortly. And then if patients already have diabetes, then the protocol is the same. But if their blood glucose is less than 12, you should not be changing any of the medications, apart from the ones that we've already discussed, as in stopping metformin, SGLT2, or GLP-1. Otherwise, you can continue their current medications. Now, if blood sugars are high, and blood sugars are very high, for example, if they are more than 15, or if they have ketones of 1.5 to 3, then you can give them shots of quick-acting insulin, which can either be Actrabit, which is short-acting soluble insulin in Pakistan, or Humulin R, you can say, or you can give them Novorapid or Humalog, which is ultra-quick-acting insulin. I prefer Novorapid and Humalog. If they do not have diabetes, then you want to start them on an intermediate form of insulin, which comes in the form of Insulatard, Humulin I, and Humulin N in Pakistan. This is a rough calculation of about the dose. The dose can be more or less, so that you want to start them on a total daily dose of 0.3 units per kilogram. For an 80 kilogram man, this turns out to be 24 units. So you want to give them 16 units in the morning and 8 units in the evening. So 8 o'clock and 6 o'clock. In patients who are elderly, for example, more than 70, 75, or who have renal disease, you might want to start them on half the dose. And patients who already have diabetes but are insulin naive, and the blood sugars are high because you have stopped their metformin, GLP-1, or SGLT2 inhibitors, then what you do? Then if they're not eating, then you want to start them on intermediate acting insulin. Again, the similar forms which I discussed, Insulatard, Humulin I, or Humulin N, but the dose is slightly higher, which is 0.5 units per kilogram. This is based on the fact that patients who already have diabetes may have some insulin resistance. Now we're talking about type 2 diabetes here mostly. And then if they are eating, you want to also give them quick acting insulin along with that to cover the meal. So you want to give them twice a day insulin mixed form, which is like Humulin M3, Novamix 30, Humalog mix 25, 50. In Pakistan, you can have Humulin 70/30. You give 2/3 the dose in the morning and 1/3 in the evening. This is because of the fact that steroid-induced hyperglycemia is worse in the day and becomes better overnight. So how you increase or reduce the dose? This is a rough guide of how you want to do it. So if you have hypoglycemia, you want to reduce the insulin dose by 20% or even more in some cases. If the blood sugar is tightly controlled, as in 4.1 to 6, you want to reduce insulin by about 10%. But if it is in the target range, you don't want to do any changes. If the blood sugars are high, you can increase the insulin dose by up to 50%. I've actually managed to increase insulin by more than 50% in many patients. So it's individualization, and you as a clinician, you would know which persons are at high risk of insulin resistance. For example, people who are obese have stigmata of insulin resistance and are on very high doses of insulin to even start with. And then people who are on once a day insulin, for example, somebody with type 1 diabetes who's already on Lantus or Levemir, this is a rough guide, a very similar guide to the last one, to reduce the insulin accordingly. Now, this is a rough chart. I wouldn't go into much of the detail. This is about the sliding scale of subcutaneous quick-acting insulin you would want to give to the patients who have fairly high glucose levels. You could give according to the level of glycemia and according to the weight and ketones, the units of insulin increase. So you can see if somebody's blood sugar is very high, more than 27, they are overweight. And indeed, if they have ketones, you will want to give them higher units of insulin. But if the ketones are more than 3, you must check their acid and base balance to ensure that they are not in decay. Now, what happens when you stop dexamethasone? So interestingly, your insulin resistance at times steps. So you do not want to stop their insulin completely. You want to reduce it by half and see how but not very high. You would want to reduce insulin by 10%. This is in between 15 to 18. And if the blood sugars are slightly raised, you would want to reduce insulin by further 20%. Now, if the blood sugars are less than 10 millimole, which is around 1.8, completely, if patient was not on insulin to start with, and you only started insulin to cover the dexamethasone. So, and I think this is really important, because if you carried on insulin and the patient is not having dexamethasone, some patients could indeed have hypoglycemia. And as you know, hypoglycemia can be life-threatening in acute situations. So what would you do on discharge? So if their HbA1c, so steroid-induced hyperglycemia, if their HbA1c is more than 69 millimole per mole, which is equivalent to 8.5%, it means that they will require escalation of diabetes treatment. You would want to make changes to their usual treatment. Obviously, you may want to stop their metformin, sulfonylureas, GLP-1 agonists, or the SGLT2 inhibitors. But I think they also need some kind of extra treatment, which may well be insulin. And this requires input from your diabetes team in the hospital. But if they were not known to have diabetes on admission and the HbA1c is less than 69, which is 8.5 millimoles per liter, it means that they probably had insulin, which is excessive. They probably had diabetes due to insulin resistance, and it became worse because of the steroids or got unmasked. They probably don't need any intensification of treatment, and you would just want to repeat their HbA1c in 3 months' time and ensure diabetes follow-up. Or if you're the clinician following up patients yourself, then you would want to see them in 3 months' time, making sure they are not developing diabetes. Unless patient had a lot of ketones during admission, or patients with admitted decay, in which case they would definitely need insulin. If patients who had known to have diabetes and their control was adequate, you would just not change any medications and discharge them on the same cocktail of treatment that they came in on. I think it is important to discuss the other considerations. For example, many patients have asked me about CGM, which is a continuous glucose monitor, or flash glucose monitoring. And I think there is a role of these treatments if the patient is already on these treatments. So just to say that if you can see this If you can see this, this gadget, this is a Freestyle Libre, also called as a flash glucose monitor. This check the blood sugars from beneath the skin regularly and gives you the readings. This is 6.2 millimole per liter, and this is the arrow. This tells you that the blood sugar will be going up, and it gives you the profile of whole over the day. If you can see this gadget, and that is how it is inserted. So once you insert it, this stays in the arm for about 14 days, and it can give you regular blood glucose values from the interstitium. So it is a really valuable tool if patients are able to self-invest. The problem is obviously availability. I'm not sure it is widely available in Pakistan, but I do know that some patients have ordered it from the UK. Pregnant women. So all patients who are at the childbearing age must have their pregnancy test done if they are unwell. So we talked about the case. We talked about case number 3. There was a 33-year-old lady admitted with slightly high blood glucose levels, probably in DK. But you also want to make sure she's not pregnant, because that has on its own has implications, and you would want to involve the gynae team as soon as possible. And then people have asked about COVID-19 vaccination. I think it's absolutely imperative that all patients who are offered, all patients with diabetes who are offered COVID-19 vaccination should have it, as long as they do not have contraindications, usual contraindications, for example, severe hypersensitivity, etc. This is important as people with, as Jawad has talked about it, people with diabetes are at very high risk of morbidity as well as mortality with COVID-19. Now, how can you support patients with diabetes remotely? Now, if you are confident, you can ask patients to have to do online self-management courses. This is the patients knowing how they can manage their diabetes themselves on day-to-day basis, and discuss the optimum use of technology. We just talked about flash glucose monitoring. If they are on insulin pumps, how to deal with insulin pumps. I think it's, as clinicians, it is our responsibility to teach our patients to do this. We should be ensuring patients are regularly checking their feet, because this is the area that is most commonly missed. And people develop foot ulcers. They have neuropathy. They don't know that they're developing foot ulcers. Lifestyle is really important. COVID-related restrictions hasn't made it easy. I think it is very difficult to keep your weight under check, but I think this is really critical. As your weight goes up, your insulin resistance will get worse. And on top of this, psychological health is also important. You know, talking to your friends, you know, and going out for exercise, and above all of that, you should be following, you know, educating our patients to follow the guidelines, masking up. You know, CDC have even recommended now to have 2 masks to avoid transmission of COVID-19. Then, you know, hand washing and obviously safe distancing measures. Now, how do you want to treat a person with diabetes that has got COVID, but he or she is not in the hospital? So first of all, don't panic. COVID, although, you know, in diabetes, COVID-related mortality and morbidity is high, you know, you don't want to take unnecessary stress, which will make things worse, especially your insulin resistance. Obviously, needless to say, you would be treating them symptomatically, but must not use steroids if they're not clinically unwell. If they're not needing oxygen, if they're not unwell in any way, I think it's not recommended to have steroids, because I think they will make things worse, not any better. Maintain hydration, monitor the glucose levels, follow the sick day rules. We'll talk about sick day rules shortly, if that's okay. And then you want to support them to adjust their medication. If they become, you know, dehydrated, you would definitely want to stop SGLT2 inhibitors, etc. And you would be suggesting them to contact their healthcare provider, endocrinologists, preferably if needed. So what are the sick day rules? So I think this is general advice for patients who have diabetes, especially type 1 diabetes. Stay hydrated, eat normally, check your blood sugars regularly, checks for symptoms of high blood glucose, for example, dry mouth, thirst, passing large amount of urine, and especially in the night, tiredness, you know, weight loss, and monitor ketones. If you're unwell, check your ketones because you could develop ketones and not know. And DK can develop rapidly in some cases. There's also an advice to check your fever twice a day. I'm not. This is quite an old guidance, and I'm not sure I agree with all of that. Checking fever twice, but if you are unwell, check your fever regularly. Yes. So this is just a guide on what medications you should be stopping. We've talked about metformin. We've talked about SGLT2 inhibitors. There are some other medications. Sulfonylureas could make you at high risk of hypoglycemia. ACE inhibitors. I think there was a lot of fuss about stopping ACE inhibitors initially, but there have been a big study from Brazil suggesting that ACE inhibitors should be continued in patients who have COVID, but it depends on if they have acute kidney injury or not. So there are other factors as well. Diuretics, ARBs, same as ACE inhibitors, and NSAIDs because patients are at high risk of acute kidney injury. As they've said, insulin is a preferred agent in hospitalized sick patients, which we've already talked about. So seek advice. If you don't know what to do, speak to your diabetes team, speak to your endocrinologist, speak to your physician. If you're vomiting repeatedly and unable to hold down your food and drink for more than 6 hours, you may need to be coming to the hospital to get treatment. If your blood sugar is very high for more than 24 hours, or if you're showing signs of decay, which are below like ketones or in the blood or in the urine, excessive thirst, polyuria we talked about, shortness of breath, abdominal pain, and mental confusion, fruity smell. So if this all happens, contact your healthcare provider because you may need hospital admission. So I'll stop there because I think I've taken a lot of time. Sorry, Kashif. But if somebody has any questions, I'll be very happy to answer them.
No, Rahat, that was a very nice, discussion, especially with the fact that our system has been, properly, hacked, which was causing quite a lot of disruption. And at least I have received about 20-25 messages from the attendees who really like to attend. And due to that, hacking, those young doctors who like to learn, who like to do something for the community, for the patients, are being deprived. So I feel very sorry for them. That a small, joke or a small, time of excitement to hack any teaching session leads to the compromisation of the patient care. They don't realize that one day those few people who have hacked it might run into problems, and we are the doctors, we will be the one who will be saving their lives. But still, I will bless them, and I hope they will not do it again. Dr. Habib, I will give the mic to you. Then if you can, shed some light on your teaching also.
Thank you so much, Dr. Kashif Chauhan. And I think it's really what you call is heartbreaking to see that somebody try to hack such an informative and helpful session. And I'm extremely thankful to my other colleagues, Jawad and Rahat, who explained very well. And unfortunately, due to time constraint, they were not able to continue what they're supposed to do. So I'm just going to share my screen. So hopefully you guys can see the screen. Is that right? Can you see my screen?
I will stop sharing my screen.
Yeah.
Sorry.
Now we can see your
Yep.
screen.
Yes, I can see.
Okay. So I'm Dr. Habib Haider. I'm working as a consultant in acute medicine and stroke medicine. And during this pandemic, as a frontline medic, I come across two different cases. And as I said before, that Jawad and Rahat explained very well the complication of diabetes related with COVID-19. As we know, these are very difficult times in dealing with the patients who can present with both complications and also the initial risk factor of diabetes, which can lead to major problems. So COVID-19 can present in different ways in terms of cardiovascular problems. As you can see on this busy slide, that it can start with a simple viral infection, which can result in acute respiratory distress syndrome. But looking on the other side, it can cause cardiovascular complication with the help of initial manifestation like acute cardiac injury, in which can be increased like troponin levels, or could be a myocarditis, which could be injury to the myocardium, and also like acute coronary syndrome, which is like ST elevation or non-STEMI or sometimes unstable angina. And it can also result in arrhythmias like atrial tachycardias, ventricular tachycardias, and atrial fibrillation. And the major risk factor is regarding the coagulation cascade pathway that it can result in thromboembolism things, which can result in systemic inflammation and eventually result in this cardiovascular complications. As my colleague explained before regarding some of the drugs, those has been controversial initially, including ACE inhibitor and ARB. Those are the cornerstone for the coronary artery disease and also for the diabetic treatment. We can use, but we need to take extra caution in view of acute kidney injury and other complications. This busy slide tell you about the mechanism of SARS-CoV virus, that it can result in endothelial damage and then result in microvascular changes in the coronary artery. With the help of endothelial injury, it can result in endothelial dysfunction and subsequently plaque rupture. And this all result in due to inflammation, which can increase the cascade pathway regarding the cytokine storm. As we guys all know that the cytokine storm is a lethal combination which can result in severe complication in terms of COVID-19 and can result in worse prognosis and increased mortality rate. It can also result in activation of immune system, which can result in people in more severity of the presentation of their diseases in view of acute coronary syndrome. In terms of this COVID-19 can result in thromboembolic pathway, like in terms of coagulation cascade, arrhythmias, in summary, myocardial infarction and stroke, and direct cardiac injury as well. COVID-19 also can result in complication in terms of stroke. Basically, as you can see that the heart attack is more or less similar to COVID-19, like a brain attack. In this slide, you can see clearly the CT scan shows a severe and significant damage to the lung parenchyma, resulting in bilateral patchy consolidation on chest X-ray, which can further actually clarify on this CT scan. And then on the right hand, you can see that the major large vessel occlusion, like a middle cerebral artery, which is a major cerebral artery supply in terms of dominant person who has a right hand dominance and the left side of the brain. So it's all gone. So stroke can also present like in terms of various, like in terms of COVID-19. It not directly indicative of like a severity of the stroke, but can result in sometime a impact on the stroke services. That during this COVID pandemic, some of the people, those have the initial presentation of stroke, they were not able to reach on time because they were scared. So some of the minor stroke unfortunately missed. But at the same time, when they presented to the hospital, they were at a severity of the state that they're not able to have the initial treatment like thrombolysis or thrombectomy, which is the new modified treatment for removal of clot in terms of acute stroke. There was a study on Stroke Journal which mentioned about the emphasis of the stroke and COVID-19, which shows that the patient have not as such a high number of stroke, but they have an increased mortality rate due to coagulation cascade, as we described before in terms of myocardial injury. And also second cause is the sepsis and intravascular coagulation. So in summary, I think the COVID-19 can result in major complications, but those people who have already had diabetes and hypertension can increase the rate of mortality among hospitalized patients and can result in various complications. So my only message, as my colleague earlier said, as per the Huzur Sallallahu Alaihi Wasallam said, that please stay at home, protect NHS and save life. Thank you.
Thank you very much, Dr. Habib, for a very nice and concise knowledge of your topic. That is really nice of you. That it was right on spot that the people really like to know that what exactly is happening. So I've got I've received quite a few questions. If I can ask the guest, panelist, that if they can be brief and answer, few of those, questions. And due to that disruption, Unfortunately, we have to cut down our session a bit. So I will start with Dr. Jawad Bashir. Uh, Dr. Bashir, if you can ask us, there is a question that why is the mortality higher with COVID and coexisting diabetes?
Thank you, Kashif, and thank you to the other speakers giving a very nice talk on this. With regards to this question, it is still an interesting area of for research. We don't know exactly why the people with diabetes do worse, but there are several hypotheses which include either it is a thromboembolic state, inflammatory state due to hyperglycemia, which leads to microemboli. And the cause of death could be anything like ranging from severe COVID infection to a pulmonary embolism. But when you have diabetes, you're more likely to get those complications with COVID, also including renal failure. Diabetes, as we know, is known to cause all thromboembolic events. So that is one of the potential hypotheses explaining worst mortality outcomes.
Oh, that's very nice, very nicely answered. I've got another question for you that what advice would you give to your patients with diabetes during this COVID-19 pandemic? I think so. This is a very relevant, question. Somebody just, posted and asked. So if you can kindly just throw a light on it.
I would go back on my third slide in the presentation, what our Prophet Muhammad Sallallahu Alaihi Wasallam mentioned about the pandemic. If you have a pandemic, please do not socialize, do not go into gatherings, stay at home. That's a generic advice for everyone. If you have diabetes, we know it is a more lethal combination. What you can do for yourself is to ensure that your diabetes control is as good as it can be, whether it is with medications, lifestyle, healthy activities. Stay well hydrated. Do not skip your medications. Do not skip monitoring. So these are simple things. If you are unwell, then as Rahat has shown a few things, that some of the medications would have to be held off, especially the newer ones, which I'm sure a lot of people are prescribing in Pakistan, the SGLT2 inhibitors, they should be held off because it's a higher risk of decay, and GLP-1 will cause vomiting as well. So I'm sure the patients are aware of these medications, and they should seek advice. Whenever they're not certain, they should seek advice from the experts.
Thank you very much, Dr. Jawad. These are, very nicely answered, questions. Can I move on to Dr. Rahat Ali? Dr. Rahat, I've got, a few interesting, questions for you. The first one is that why does COVID infection cause worsening of hypoglycemia and diabetes?
So I think I probably explained that, which got missed because people were unable to see attend the Zoom meeting. So there are a few things. First of all, as you know, with any illness, you have the stress of the illness that causes hyperglycemia, number one. And number two, there is evidence suggesting that COVID increases insulin, and if it is not present, it induces insulin resistance at the level of the peripheral tissues. So whatever insulin is present in the body is unable to act in the same capacity as it would have if there was not much insulin resistance. Thirdly, there is evidence that COVID-19 can directly affect and even cause toxicity of beta cells, which means that you will have less insulin in the system. And fourthly, as you know, most of the patients who are hospitalized and are unwell need steroids, and this causes additional insulin resistance. So there are a few things that causes, that cause hyperglycemia in patients who already have diabetes. So I hope that answers the question.
Yeah, no, I think so. That is very nicely and precisely, answered. The next question I have for you is, can COVID infection cause diabetes?
Okay, well, I think somebody is asked a very nice question. I think this one is very relevant. So the data is scarce at the moment, so we don't have enough data to confirm whether COVID-19 can cause new onset of diabetes. Now, when I say this, I mean to say type 1 diabetes. But there is some evidence that COVID-19 can can cause toxicity of beta cells, causing insulin-dependent diabetes. Now, this can be via direct toxicity caused by, for example, ACE2 inhibitors, which are actually present on beta cells, but also by immune modulation, production of autoantibodies that cause diabetes type 1. Now, with type 2 diabetes, it generally unmasks already present diabetes. So if somebody has diabetes, they have risk factors, insulin resistance, obesity, stigmata of insulin resistance clinically. So the patient was not aware, and having COVID, steroids on board, that will unmask their diabetes. So I think we are still unable to know whether the type 1 diabetes caused by COVID-19 is just a correlation, or if it is actually a causation. But I think only time will tell. There are studies coming, so we'll see.
Thank you very much, Dr. Raid. I think so that somebody has sent a question directly to Dr. Jawad. Dr. Jawad, if you can just tell us that what is the question and what will be the answer?
Thank you, Kashif. It's from one of my endocrinology consultant colleagues, Dr. Masood Alam. He asked that from the study that I showed of Parthakar, that 1/3 of the people with diabetes, 1/3 of the deaths in the first wave of COVID in UK were people with diabetes. So he asked specifically how many of those had obesity and metabolic syndrome, because we know these are a few other comorbidities with diabetes, with which patients do far worse. Interestingly, I looked at the data again after this question, and about 50% of the people who died with COVID and diabetes, their BMI was below 35. Now, normally the patients who have type 2 diabetes, we see a lot of patients with obesity whose BMI is much higher than 35. So although 30 to 35 comes in obesity range, but 50% of these are below 35. And if you further break it down, 25% of both type 1 and type 2 patients were below 30, BMI below 30. So they were not massively or morbidly obese who have died. The question about the metabolic syndrome, again, very interesting. 60% of patients who died with diabetes and COVID, their total cholesterol was below 5. So the answer to that question is that diabetes is an independent risk factor in relation to COVID-related mortality. These people were not massively obese. They were not having the severe metabolic syndrome in which you see them having dyslipidemias. So diabetes and COVID is a lethal combination. This is what I would say. Thank you.
Thank you very much, Dr. Rahat. Oh, sorry, Dr. Jawad. That was a very nice, answer of a very difficult question, I must say. Dr. Habib, I've got a question for you also. Is there any link of COVID-19 and cardiovascular and stroke problems?
Thank you, Dr. Kashif. I think it's really a nice question. And as my colleague explained before, that unfortunately, as you can imagine, the COVID is not directly linked with cardiovascular or a stroke problem. However, having saying that, there was incidence of cardiovascular and stroke problem is much increased in COVID patients due to mechanism of injury, either in means of coagulation cascade, which will result in like endothelial dysfunction, or itself can result in impact. As you can imagine, the heart problem and the stroke problem both result in due to what we call as ischemia, like a decreased blood supply. So if you're talking about the platelets, like in terms of endothelial injury, then it can result in stasis of blood, decreased blood flow to the respective area, either to the heart or to the brain. Then it can result in stroke or heart attack subsequently. So there is no direct link, but however, indirect way, you can say that patient those have a COVID-19 along with risk factor like diabetes, high blood pressure, they are more prone to have a stroke or heart problems.
That's really nice of you, Thank you very much, Dr. Habib. So I've got one last question before we can, close this session. This is a question for Dr. Rahat Ali, which has just been posted. The question is that, can pleural effusion be seen in COVID patient? I think so. It's Dr. Rahat Ali and Dr. Habib can both can answer this question. So I'll let you that who will be answering this question. The question is, can pleural effusion be seen in COVID infections?
So, Rad, is it okay for me to answer as a
Yeah, I think you should answer. It's not my area of expertise, but yes, I'll let you answer.
Yeah, or Jawad, because
Yeah.
Jawad can answer, or Habib can answer. You both can share answers. Yeah.
So as an acute physician, yes, we have come across lots of patients with the COVID-19 pneumonia. The problem is that the COVID-19 can present in different ways. It can present like a acute respiratory distress syndrome, what we call non-cardiogenic pulmonary edema. So if you're talking about non-cardiogenic pulmonary edema, yes, you can say pleural effusion on the chest X-ray. But you need to think about either you could thinking about simple pleural effusion, which means that the fluid in the pleural cavity, or you're talking about a non-cardiogenic pulmonary edema like ARDS. So it's very difficult. So that's the reason the gold standard test is CT scan, where you can look for specific finding, which means the periphery's involvement and see the parenchyma involvement at the same time. Then you can differentiate whether you can see a patient who has a COVID-19 who present with a pleural effusion, what we call as like a parapneumonic effusion as a result of pneumonia, or they're talking about ARDS, which is non-cardiogenic pulmonary edema. So it varies from person to person in terms of clinical presentation.
Thank you very much, Dr. Habib. And I must say that, I'm really grateful to all our three, respectable speakers, that despite of the fact we run into problems, we pulled ourselves up. It's just like that you are seeing a patient and all of a sudden, what you call it, a heart or a trauma bleep, because I'm a surgeon, so only thing which comes into my mind is a trauma bleep. And you are a physician, the thing which comes in your mind is 222 or 999. So you can
Cardiac arrest.
Cardiac arrest.
Exactly, the cardiac arrest bleep. That's what that's the exact word I was looking for, rather than a trauma bleep. Okay, so the cardiac arrest bleep was being activated, which leads to the trauma bleep. But thank you very much that you all three had pulled it out very well. Unfortunately, we have to close down the meeting. We have to reopen the meeting. My special apologies to our participants that we didn't allow them to join our Zoom meeting, because we don't know that who was the hacker who was in that meeting. Still, there are two participants waiting for the last half an hour for me to enter them. So apologies to those participants also. But we have to take some steps just to make sure that this teaching session runs, comfortably. So it's all on the Facebook. If you want to post any question, please post it on the Facebook, and our respected speakers will be able to answer you directly on the Facebook. So once again, thank you very much, all of you, for a very nice meeting. And I'm going to stop the live streaming now.
Thank you.
Thank you.
Thank you,
Thank you, Kashif. Thank you.
Thank you.
Nicely done.
Just
Thank you.
stop the